start. Yeah, I don't know. Is Benda back? Benda, are you back? Oh, yeah. Thank you. So I think we, yeah. So good afternoon for those in Africa and good morning for those in US. I would like to welcome everybody once again in today's session and to this African Cancer Control and Research Echo. My name is Annette Nakaganda, a cancer epidemiologist based at the Uganda Cancer Institute, and I chair the steering committee for this echo, and I'm going to be leading today's session. A special welcome for those attending for the first time. This is the African Cancer Research and Control ECHO, and as you may have heard, it aims at expanding and sustaining best practices for cancer control planning and implementation, in particular using evidence in directing the cancer control effort in the African region. Today's session that we are going to have, let me just pull out the agenda briefly. Today's session is about patient and healthcare worker messaging, communication, and mental health. And as stipulated on the agenda we are going to specifically share best practices in messaging, virtual communications, mental health considerations for cancer patients and as well as health workers. And we are going to discuss ways to advocate for continued safe patient care during the pandemic. So we had planned to have two short presentations today, one given by Benda Chitaka and another one by Achille. But I've learned that Dr. Achille may not be able to join us. Let's see how it goes. But if he does not join us today, we are honored to have Dr. Julie Glalo, who will be able to moderate the discussions, and then we can have a more detailed discussion of the topic around communication in pandemic. So I'm going to take this opportunity to invite Benda, but before I invite Benda as the first speaker, I want to remind you to mute your microphones if you are not speaking, please. And if your bandwidth permits, please turn on your video, as we like so much to see your faces as we discuss this. In addition, please use the chat window at any time during the presentation or the discussions to introduce yourself, ask questions, or make any comments. I also want to remind you that sessions are going to be recorded and will be sent out to those who shared your email contacts with the African Cancer Control Research Secretariat. So I'm highly honored to invite Benda Chitaka to take us through the next session. Benda Chitaka is a co-founder of Women for Cancer Early Detection and Treatment in Kenya. She's a health advocate and behavior change communication specialist with over 20 years of experience in communication research and health advocacy. She sits on various local and global technical working groups in advocacy and advocacy role. She co-chairs the Oyotic Advocacy Special Interest Group and Stop Cervical Cancer Technical Working Group. She's also an instructor in advocacy for women's health. Benda has received various awards, including the International Gynecologic Cancer Society Distinguished Advocacy Award 2019, the UICC Award to participate as the civil society voice in the regional consultation on the elimination of cervical cancer in African region. She's also the Cancer Ambassador of the year 2016 in Kenya. Her advocacy work includes writing the WHO Afro chapter on advocacy for cervical cancer prevention and control in Africa, Facilitator Manual 2015-2017, and also writing a trainer's manual in use of the toolkit in Africa. Benda is currently planning a Mount Kenya climb with cancer survivors slated for September 2020 to highlight cancer survivorship challenges and advocate for post-treatment empowerment. So we are honored and excited to have Benda share with us her experience. And Benda, over to you.
Thank you, Annette, and thank you all for attending this session. I'm going to be speaking on patient and healthcare worker support and looking at the needs on messaging, communications, and mental wellness. And I'm going to be sharing my slides. Hopefully, technology will not fail us today. Can you all see my slides? Is it visible, Annette?
Yes, it is visible. Brenda, we only need you to put it in the slideshow mode. Yeah, excellent.
In slideshow mode, yes.
Yeah.
So that is visible now, right?
Yes.
So I'm going to be speaking on cancer advocacy during COVID-19 pandemic.
So yes,
And initially, sorry? Can you
sorry,
hear
go
me?
on, Brenda, go on, sorry.
Okay. And initially, when I was thinking around how do I tackle advocacy, which is a big subject, on a 8 minutes presentation, it so happens that I realized there is one thing that we all need to be cognizant of, and that is we work in a cancer care ecosystem that has a lot of people, all of us working towards the same common goal, and that is the patient. And so when I was thinking about what is it that drives us, the healthcare system, the government regulations, the environment dynamics that we're working with, industry players, ministries of health, technical advices, it's all about the patient, and we want the best outcomes for the patient. Ultimately, we all would want that advocacy works towards putting the patient at the center of the work that we do. And so looking at the COVID-19 and what has happened with cancer care across the region, because if you read up across what has been coming out from various researches that have been done, if you look at what has been written in the media, and if you talk to cancer patients, you'll get to hear that there is quite a bit of changes in the way that we are handling our patients. COVID has come and little virus has sort of taken center stage on all of care. There is delays in services being provided. For example, in Kenya, in terms of vaccinations, we're seeing lower numbers than we did. Last year, we introduced the HPV vaccine. Right now, the second dose is due, and we're having challenges with that. Screening is almost non-existent because people are not going to the facilities and because they're afraid of COVID-19, not because of cancer, which used to be the bigger fear before, but because of the fear of the COVID-19. In the US and other regions, there is telemedicine. In Africa, when we talk telemedicine, it's a question of if somebody has data to even call the doctor and if they can be able to get the interventions that are required. For example, elective surgery has been sort of put on the back burner to be delayed until such a time as the situation opens up. There is also the change in treatment algorithms. More and more of the clinicians and the oncologists that I've talked to are saying they're doing more of oral chemo as opposed to chemo at the hospital setting. Various studies have also shown that there is the issue of survivorship. If you think about patients being reintegrated into the community, their fear of recurrence, if someone has something happening in their body right now, they're more afraid of going to the hospital to get checked than they are afraid of the cancer recurring. And yet we know the journey that these patients have gone through. There is the issue of stigma, because with cancer patients, there is a higher risk of adverse outcomes. And therefore our patients are afraid of even being exposed or even getting into contact with the healthcare system that has served them in the past. If we can look at Kenya and cancer versus COVID, the reality is numbers that came out last year, 47,000 cancer patients in 1 year. COVID, we're talking about 3,094 cases in the last 3 months. We're talking about the kind of testing that has been done on COVID, 98,439 as of yesterday, tests performed. I cannot tell you with certainty how many of our cases of cancer in Kenya is happening or has happened in the past. And therefore we can see there data surveillance and cancer care being a need and being an issue that has not been very well addressed as has been addressed with COVID-19. The other thing is in Kenya, it's not all doom and gloom. Cancer care is still an essential service. It is still being given the center stage that it requires by the Ministry of Health. So we have the medicines available, the chemo centers open, clinics still running. However, there is a delay in procurements because right now there is a focus on bringing PPEs and bringing interventions for COVID as compared to cancer. So you'll talk to patients who require Herceptin, for example, and they say they don't have it in the National Referral Hospital. And if they go to private healthcare, the price is almost double. What do you tell such a patient who could not afford the one in the public facility, and now you're telling them to go to the private facility for that? Civil society has also been affected by COVID. We used to have palliative care services. We used to have survivorship groups, psychosocial support groups. And I've seen one of our participants today is actually from one of the organizations that offers very good psychosocial support in Kenya. For 2 months, that service had been delayed because they needed to find a new way of doing things online. We have a limited public gatherings, and because some centers, some towns in Kenya are under lockdown. For example, Nairobi, people cannot come to seek services in cancer care, all because COVID-19. And therefore, just to demonstrate, we have one national referral hospital, which is Kenyatta National Hospital. In March 16th, there was a public notice about restricted public access to Kenyatta National Hospital. That has not changed. The clinics are still running. Monday to Thursday is the cancer clinics, specialty clinics, but access to this is delayed by various other actions that have been put in place to mitigate COVID-19. For example, there is a COVID-19 isolation ward that currently is in place just next to the accident and emergency, where anybody who is coming in before they are taken to the wards, they are actually put in the isolation ward. And that's what I want to present as a case study today. On 4th of June, that was last week, Thursday, a patient was brought to our attention. She's a mother, single mother of 3. Her eldest daughter is 21, and she's the primary caregiver. This lady was being treated in a center 320 kilometers away from Nairobi. The center doesn't have radiotherapy. And as you can see from the image there, she has an eye that requires radiotherapy. She was referred to Kenyatta National Hospital for radiotherapy services in April 2020. Because of the needs of the patient, both in finances as well as means for her to travel to Nairobi, she has no one to stay with in Nairobi. Therefore, she needed to find accommodation. She reached Nairobi on 26th of May. However, with the system going to Kenyatta in the morning, being told, sorry, the clinic is next week on Monday, come back next week Monday. She was staying in a place which is very familiar to a number of you maybe, which is Kibera. Now, this patient, the eye cannot be bandaged, and therefore it's oozing, and therefore in the hospital, in the community, she has to hide herself because stigma, because fear, and yet people are afraid also of COVID. She has tried going to Kenyatta for a number of days, and finally, ultimately, when she came to our notice, we were able to get her to go to Kenyatta. And this is the timestamp that I want us to go through. Thursday last week, we get a WhatsApp image of her. We recommend that she goes to Kenyatta, and we give her instructions on where to go. But she goes to the casualty because that's where every patient reports to. It took about 3 hours for her to get to the cancer center. By then, the clinic was closing. By that time, we talk from an advocacy perspective to the cancer center, and they say we will refer her back to casualty so that she can be taken through the mechanisms for her to be admitted. At casualty, they take their time, regrettably, because they're overwhelmed. The healthcare system is, Kenyatta National Hospital caters to all specialty clinics, and therefore she's yet one other patient who needs to be attended to. It took threatening to give media attention for her to be admitted, And by that time, they had said they were going to infuse her with oxygen, and then she can go home and come back on Monday. That was Thursday. Little did we know that she gets to the ward, isolation for COVID-19, and the results for the test that has been taken was supposedly going to come out on Saturday. Fast forward to Saturday, no results. The patient is weak, not feeding well. By Monday, results are not out. Again, COVID-19 results not out. Patient has missed the specialty clinic for Monday. And in the same note on media, we get news that the Ministry of Health is looking at a new supplier for reagents for the test. And that's the reason why the test has been delayed. Regrettably, the primary physician who was seeing her in Eldoret has lost a family member. And therefore, this primary physician who has been in constant communication with the cancer center in Kenyatta is no longer able to focus on the patient because they're focusing on their own health, grief, and helplessness. Fast forward to yesterday, still no COVID results, and it took threatening to call the media again that the tests were finally going to come out today. There is some good to report on this. By yesterday, the results were not out. By today morning, this patient's results came out as negative, and therefore they are being taken to the cancer ward to start receiving the necessary treatment, including palliative care. By today, 1 week later, her condition has deteriorated because the swelling has affected the mouth and the glands in the mouth, so she's not even able to swallow. So you can imagine from last week to today, how much change has happened. I brought this case to you because I wanted us to think about the challenges that we are facing that we need to focus on. Delays, changes in treatment. She was brought in to get radiation. She ended up going for isolation for COVID-19. Stigma at the community, they were hiding from her. At the hospital, they were afraid of the eye, but also afraid of COVID-19, and because she had a fever, they were thinking we need first to isolate to see whether it is COVID-19. The systems, no testing kits, delays in getting results, no PPE for cancer care staff, therefore they cannot go to the isolation ward to administer the necessary care, and the stigma of infecting other patients. If she came out as a COVID-19 patient, then there was the fear of if we put her on a radiotherapy machine right now, before we know about COVID-19, what will happen with all the other patients that will need to use this machine? And systems and challenges with healthcare system, where we're looking at procurements and resources for both cancer as well as COVID-19. That brings me back to the second last slide, actually, brings me back to the cancer care ecosystem. What has COVID-19 taught us? That we need to start thinking that indeed we have to accept everything has changed. It's no longer all systems as they were before. Will this end up being better for our patients, or will we regenerate to what was before even COVID-19? We've realized how much we can get as a fast response to a common goal. COVID-19 has gotten so many resources directed at COVID care. How much of that is coming to cancer care? Leadership and communication. Every single day we get a government official talking about the number of cases tested, the number of cases found positive, the number of the deaths reported. Cervical cancer kills 9 women in Kenya daily. We don't get to hear about them until results will be released as an annual report. So leadership and communication. Opportunities that exist, inclusivity and trust building in our advocacy. As we said, it's an ecosystem. We all want the best for the patient, and we want the patient at the center of the work that we do. How can we reduce the biases that exist on expertise, on what each person has to bring to the table, and what value we can all bring together when we work as physicians, clinicians, patient advocates, their family and caregivers, and even the Ministry of Health? How can we work together to bring that advocacy to the core? And lastly, on advocacy, because things have really tremendously changed, How do we bring flexibility and innovation to make sure that we have constant communication, addressing the needs of the patients, but also of the caregivers? Who is minding the physician who has lost a parent and yet has to continue working for the care for the cancer patients? And cost management, the cost of cancer care versus the cost of COVID-19 versus the systems that are being put in place for COVID-19 that could also serve for cancer care. Resource mobilization and sharing. How do we make sure that our patients are served right, no matter what the disease? Because I'll tell you, COVID-19 is here, a vaccine will be found, hopefully, solutions will be found quickly, and we'll move back. What are we moving back to? Malaria, communicable diseases, non-communicable diseases, the dual burden that we all know very well. Systems and structures that have been strengthened for COVID-19, will this also work for us? And ultimately, when we think about it, if we're telling people that we need to take care of cancer, are we also taking care of the other necessary items? For example, just this week, our cancer patients have been advised to use N95 masks. These things are costly. How do we advocate for them? Lastly, I want to pause here and ask us a number of questions. How do we all advocate to ensure that the immunity, psychosocial, financial, and spiritual needs of our patients, as well as caregivers, as well as the clinicians, are taken care of? How do we ensure that communication minimizes exposure and risk, and even the other things I've talked about, like stigma, both at the community and healthcare system? How do we make sure that our doctors' mental wellness needs are met? And lastly, how do we make sure that our healthcare system copes with COVID-19 and post-COVID-19? I've done a bit of references here in case you want to read more on what is happening in various other scenarios, but I will pause it there and leave it to you, Annette, so that we can have the discussion. Thank you.
Yeah, thank you so much, Brenda. This is really a fantastic presentation and really timely, especially in these times of COVID-19 pandemic. So I would like to remind you, it looks like we don't have Dr. Achiet Mishka, do we?
No, I don't believe he was able to join. So just so you all know, we did do a pre-recording of his presentation, and I will share the link to that along with his slides. And he was sorry to miss this, but due to the clinic at the Rwanda Military Hospital, he was not able to join us today.
Yeah, Dr. Achi was specifically going to highlight about the communication and between the health workers and the patients and the messaging and so on. But we have the recordings we can be able to listen to after here. So you are all welcome with your questions, and I'm happy to let you know that Dr. Julie Glalo is going to take us through the next session of brainstorming on this and deeply discuss on the experience of Kenya presented very well by Brenda. So before I invite Dr. Julie, I would like to briefly introduce Dr. Julie. Dr. Julie Glalo is a professor of breast medical oncology and global health at the University of Washington School of Medicine and Fred Hutchinson Cancer Research Center, Seattle, and a director of breast medical oncology at the Seattle Cancer Care Alliance. She's currently involved in breast cancer clinical care, education, and research, with a focus on addressing breast cancer health care disparities locally and globally. Dr. Glalo is Executive Officer for Breast and Lung Cancer for the SWOG National Clinical Trials Network, and she has conducted local and national clinical trials related to breast cancer treatment, prevention, and survivorship. She is the founder of the Women's Empowerment Cancer Advocacy Network, a group dedicated to empowering women cancer patients advocates in low and middle income countries, with a focus in Eastern Europe and Central Asia, as well as East Africa. She co-chairs the Breast Cancer Initiative a global campaign to reduce disparities in breast cancer care. Dr. Julie, you are very welcome. I'm happy to see you once again. I have always seen Dr. Julie at Uganda Cancer Institute, so we are really happy for all the support you are giving us in Africa. So over to you, please.
Thanks, Annette, and good morning or good afternoon, depending on what time zone you're in. Benda, that was a really fantastic presentation that highlighted a lot of key points that we can talk about, and I can see in the chat that others are chiming in that there are similar cases in all the countries and in sub-Saharan Africa as well. So a question for you, Benda, and Annette, and the group is, it seems, Benda, as you went through the case, that COVID has really exacerbated a lot of pre-existing problems that in many ways existed but didn't have anything to do with COVID, and then COVID came on board and just made them all much worse, such as the access to care, such as the distance and the cost, the distance to a treatment center, the access to get into radiation, the money that it costs to stay and travel and all of that. I'd like your input on, are we through COVID going to figure out how to help some of those other pre-existing problems so that when we rebound from COVID, which hopefully we will someday, we will have a stronger system in place?
Thank you, Dr. Julie. And first of all, I would want to open it up to discussion, but I'll make my thoughts known on this one. We do realize that the COVID-19 gave us a pause. And the pause was to stop being busy at being busy, doing what we were doing always, to stop and actually reflect on where are we at. I think one of the biggest things that has come out of COVID-19 is that we now have an eye of what is possible when people congregate around an issue versus what is possible both at government level, systems level, advocacy level, and all systems strengthening to ensure that we can be able to mitigate the challenges. And because of that pause, the cancer community has been thrown with a challenge. And the challenge is, why is it that we have not put such a concerted effort on cancer, which has been a big issue for so very long? Why is it that we have so many advocacy groups on different cancer disease areas, but not the one issue that is strengthening systems for all to work? Yeah. And so I would want to open it up to discussion around, we are where we are at because COVID has put a pause on us and exposed to us the challenges that we have. What could we do differently in this space of pause, and also differently going forward in our advocacy to make sure that all our arrows are pointing at the right direction? That's the first question. The second question is, what could we do differently to make sure that we are not left in the same spot that we were in before, of distances that we have to travel, of interventions that are technologically inaccessible to some of the population, of the inequities that exist in our healthcare systems? What can we do globally as well as locally to make sure that the gains from COVID-19 and the lessons from COVID-19 do not become just that, another self-help book that is written and put on a shelf, but becomes a manual for operationalizing cancer care in our different perspectives? That's a question I would want to pose. Thank you, Julie.
Great. And since I don't know everybody on the ECHO webcast, if you want to use the chat box as a way of kind of almost raising your hand, if you want to contribute and comment on some of these topics, maybe we can keep track of the chat box so that we make sure that this is really some dialogue here as well. So Annette, I'll call on you to follow up on that, since I do.
Yeah, I can
yeah.
I can comment on that because I was thinking a lot when Brenda was really making this presentation. And from what she presented, and I was comparing Kenya and Uganda because they are almost the same countries and others. And I see Kenya looks like it's still providing cancer care in a mixture of so many diseases. And with malaria, with the, with the accidents, fractures, and so on. And definitely cancer care will be at the bottom of the list of the patients that take the management is time and planning and resources and everything, because cancer on itself is more than 200 diseases, which we have always to know. So my suggestion would be to borrow some leaf from other countries. Uganda, since it has been having a separate bit of agenda for caring cancer patients with the Uganda Cancer Institute since 1967. And it was established by the NCI USA. But through advocacy, we've been able actually to attract the attention of the government and the planners and everybody, almost giving cancer care and prevention. It's now one of the most funded institutes in Uganda, the third actually. So it is now going, even very soon it will be on top of the whole budget, I think, for Ministry of Health. So we are excited that recently, as you may all know, we government of Uganda, through a loan from ADB, we had a big chunks of money to train cancer specialists, build a cancer center, which is going to be great. But a week ago, I also learned that they got the same amount of money from Australia, and they are building another similar cancer center in Gulu. I know in the next 5 to 10 years, it will equally be the same, like UCI. So I think, first of all, advocating to make sure that cancer care and prevention is something that is too complex, as you know, the disease needs highly specialized attention. It has different causes with each disease. Prevention strategy would be too much a big step. But if we continue to manage cancer patients and plan for cancer care in general hospitals, let me tell you, it is going to be so hard. Definitely communicable diseases, malaria, Ebola, cholera, typhoid, and so on will always take priority because the death impact comes very fast. And of course, relatively, cancer will still be rare compared to those diseases, and it will not take the attention. That's what I think as one of the strategies.
Right. So, Benda, I'm struck in the case that you presented by the role of the patient advocates in getting help for this woman. And I just think about what would have happened if, you hadn't gotten involved, if somebody hadn't taken a picture of her and forwarded it, to you. And I heard you touch on that maybe we should be coming together more as advocacy groups and not, working in our own silos, but join together to better help get all cancer patients, maybe all seriously ill patients, in for treatment. Do you think that COVID can help accelerate that kind of, unification, letting people know, that you're there to help, and everybody working toward, the same thing with respect to the patient advocates and the healthcare providers all coming together?
Yes, definitely. And Julie, what I didn't highlight in that timestamp is the number of people who were involved in this conversation. It wasn't just an advocate's role alone. And I'll tell you, from the moment when they landed, when that message landed in the inbox for WhatsApp, there were quite a number of people who were involved. Kenyatta National Hospital has patient advocates and navigators who take patients by hand and directed them to the right location. If you recall, in the timestamp, I indicated that the patient got to Kenyatta casualty at 11 and only got to cancer care unit at 3 o'clock. The reason for that delay is because the patient navigator was not at the station, and the person they had reached to had other patients to navigate. Therefore, they were not able to go and pick the patient and bring them back, okay? Secondly, there was the element of the caregiver, the patient clinician who referred from Eldoret. We were in touch to make sure that they understand the delays that this patient is getting. What I didn't mention, but it's on the slides, is that this patient is a multiple myeloma patient, and therefore the eye was a condition that was on top of the multiple myeloma that they've been being treated for. And so the clinician was also following up on her treatment from Eldoret to make sure that she's adhering. There is the daughter who had to make daily trips every single day to check whether the results are out. There is a gentleman that the daughter knows that has been following up to make sure that they can go, because unfortunately the system is such that a 21-year-old girl will not be listened to as a stronger person who has a stronger voice to go there and stand up and say, this has to be done now. There is the oncologist in Kenyatta National Hospital. And this is how I knew about the fear of PPEs and the fear of contamination for the radiation machine. Because the oncologist is not just thinking about this one patient, they're also thinking about all the other patients that has to pass through this machine. And therefore for them, they did not bend to our pressure, because we were saying, why don't you take this patient and put her on a radiation machine? And they're saying, no, we have to think of all the other patients. We have to see that result. There is other networks within the Kenya Network of Cancer Organizations that we had to utilize to put pressure so that the results can come out, so that when they get the reagents, we get the first priority for this patient to be tested. Ultimately, it has also worked for other patients who are in a similar situation in the isolation ward, because all of a sudden they realize it's not just this one, because this woman was taking photos and sending through of other patients in a similar situation. Therefore, it's an ecosystem that needs to work together. And so your question is, what then do we do to make sure that there is clearer communication, there is clearer networking, there is clearer working together to make sure that we are all serving a common purpose? Annette has mentioned, cancer is not one disease. However, the challenges we face are similar. Distances are the same. If the patient has to travel from the 320 kilometers for eye cancer or leukemia, or even if it's a child, if it's an adult, the challenges are the same. Therefore, we need to separate the disease from the challenges and the systemic issues and focus on solutions going forward. One of the challenges I'm throwing is, we should not let this moment pass us. Funds are available if the need is highlighted well enough. Kenya should not be ideally having one radiotherapy machine open for public. I know there is a new one in Kenyatta University, but that has not yet been fully operationalized. We need to make sure that we can get other centers that are available to the public. A population of 50 million should not be served by one machine in a public hospital. So how can we work together as clinicians as well as advocates to make sure that the goal is not so much the one patient, but the larger population of patients that need to be addressed? Secondly, and I have to appreciate the civil society in Kenya, that we are all joined together towards a commonality of goal, which is united against cancer. But how about looking at the other disease areas? Because COVID-19 has taught us the predisposing factors and the issues around nutrition, around physical exercise, around prevention are similar to all disease areas. It's not just about cancer. How about amplifying that voice for advocacy? How about calling out the international community? Because how is it possible that billions of US dollars can be found within a month for a disease that has come up? And cancer has been with us. And we're still doing the same old, same old. Why? Can't we call it out? And so, as opposed to doing researches that showcase that we have done research and therefore we are reporting this number, could we not do application research as well? To start saying, how does this data change common practice for the future so that we're not stuck in the same spot? I think that Julie, is how I would look at it from an advocacy perspective.
I'm struck by some of this, the points you're bringing out about what's been the struggle since COVID hit and since we started adjusting our cancer practices is that balance between taking care of the individual patient in front of us, but also taking care of the whole population and protecting all patients and all healthcare providers and the community. And I found, and Mishka, I will get you this reference. I found early on that there was a very nice piece that's called Oncology Language for the COVID-19 Pandemic. It was developed by a radiation oncologist, Reshma Jagsi, at the University of Michigan in conjunction with an NGO called Vital Talk. And it's available and I will send it to you, Mishka, and you can send it out to the group. But it is lovely because I, as a healthcare provider, I'm sure other healthcare providers on this webinar, I struggled with how do I talk to my patient about the changes, the delays, balancing the acute patient in front of me and their cancer with the protection of everybody, you know, and how do you balance that? And I love the first part of it. It's just helping us with communication and language and how do we adapt in a very scary time when we don't know how long this is going to go on. Just the first general principle is the 4 C's: provide context, consideration, caring, and commitment. So I think, you know, we could all use help in how do we respond when we say to the patient, we might be changing something or delaying something, we can't screen right now, whatever. So the context is kind of sharing the why we're doing this. The consideration is, you know, highlight how you came to the decisions. The caring, express your concern and recognize the patient's emotions and their, you know, acknowledge that. And then the commitment, you know, I love kind of an example. They say, you know, part of the difficulty here is the uncertainty of how long this is going to last. But through all this, I'm going to be your doctor, I'm going to be your healthcare provider, and we're going to work together to get you the best possible care. So there's good language like this and lots of, you know, for the poor scheduler who's calling the patient to reschedule, or the nurse or the patient advocate explaining why we might be delaying things. So I think, you know, with respect to how do we take care of the patient and the healthcare provider, I think providing good language for all of us taking care of the patient to help reassure them we're not forgetting about them, we do care about their cancer, we will take care of them, is very helpful. And sometimes having examples like this to read through, it kind of gave me some new language, and I provided it with my team. And so with respect to communication, Marianne kind of asked you, Benda, a question. And Marianne, do you want to expand on your question that you asked about communication paths?
Sure, thanks, Julie. I was wondering, I know that you have showed this partial but quite extensive communication and the ups and downs of it. Living in that process, what would you recommend are the first fixes to be able to not get patients lost in the mix?
So I would, first of all, go back to what Julie has just spoken into, and that is in the context of where we are working in. For example, in the context of Kenyatta National Hospital, it's not just one cancer center, it's a specialty clinics across board, which is a referral hospital handling all manners of other disease areas. And therefore, when the patient comes, they're not just the one patient. It's one patient, there could be another one with a fracture, there could be another one from an accident, there could be another one from, and therefore the triage is to look at who requires that access now, okay? So being in that context, it's to start thinking around how else can we navigate our patients without losing the context of they are at a higher risk if exposed to COVID as well. So if in the past, for example, we would have a patient who has gone through cancer, a survivor, work with this patient. So I would have called a survivor and told them, accompany this patient to the hospital, make sure that they are seen within the next 1 hour. In the context of COVID, we're not able to send another person who is healthy right now to the hospital facility to accompany someone who is ailing. So how do we overcome that? It's to be, one, aware of the context. There will be delays, and it's not about finger pointing, it's about acknowledging that we're doing the best we can. In fact, at one point I was worried that I had sent this patient to the hospital to die in the isolation ward, as opposed to get the necessary help. Started asking, have we done the right thing to take her to hospital where she's now in an isolation ward? Should we have waited for her in the community with that eye exposed for her to go and see the doctor on the Monday clinic? Okay, that's the first, the context. The second one is open and honest communication. The caregiver and the doctor in Eldoret expects this person will be attended to immediately because it's the one patient. But as the oncologist very clearly pointed out, it's about the other patients who have to go through that machine, and therefore we have to be open with each other to say, what you're asking right now is not possible, or what you're asking right now needs to be considered in the larger context of where we are working from. But lastly, how do we make sure that delays are not causing unnecessary anguish to the patients that we are navigating? And the one thing that we could start considering as a community of practice is how else are we addressing the other barriers to care? I'll give you an example. This patient came to Nairobi, didn't have a place to stay, was booked in a place in Kibera. Kibera is a slum, slum area that is very well known globally. But if you look at the conditions in the slum area where she's living, the risk of an infection, not just COVID, or any other condition that would worsen her cancer and her eye issue is so much higher. Could we look at what other support do we need to do to make sure that patients are taken care of, they are not lost in the process? Secondly, how do we reduce stigma in the community? Because unfortunately, cancer is still considered death sentence in some areas. When somebody sees the physical manifestation of that eye, they're thinking, write off this patient. In terms of if they were on triage and somebody was being seen, somebody else who was being seen, the other person would be given a higher sort of preference because the person is thinking, I'm doing valuable work, this patient will survive. And yet we know if this patient gets the right care, they will be able to also live through with the cancer. So how do we destigmatize? How do we keep open lines of communications between physicians, clinicians, the patient, and the caregivers? How do we destigmatize the disease so that everybody sees it as their business? And also, how do we create an enabling environment that we can have open communication amongst all of us? I think one of the things that we've seen in Kenya is that, Annette mentioned I'm climbing Mount Kenya with survivors in September. And the one thing that we've seen is that survivors have come to the forefront as advocates in their own right. The last challenge I want to throw to all of us is, how do we build the voice of survivors as advocates in their own right, especially low and middle income countries? Because in the upper income countries and the developed world, that has been done very well. But in low and middle income countries, how do we start building that voice of the survivor as a credible voice to destigmatize the disease and show that they can survive the disease, but also to act as agents of change to unblock the blocks that currently exist? Because unfortunately, if I'm speaking from a non-survivor perspective, people are like, how do you know the system? But this person has gone through the system. How do we utilize that voice as well? Julie, I don't have answers. What I have is a lot of questions to get us thinking. Thank you.
Well, I was also
Yeah.
that several times in your patient scenario, there were threats to go to the media. And that
Yes.
made me wonder if we could be partnering with the media to send out more positive messages to help explain what's going on, you know, as opposed to just needing to use them when we've got a horrific case that's not going anywhere. So I think the media can potentially be our partner here, but not just, you know, for one specific case that's not getting taken care of, but to send out the right messages. So if we're talking about communication, which was Marianne's question, also maybe the media can be our partner when we have some acute things like this. So Anna, I see the top of your head, I think. You had said, you know, June is Cancer Survivors Month, and maybe COVID survivors can partner with cancer survivors. I wonder if, especially talking about the media piece, if maybe, you know, some stories of cancer patients who have also had COVID might be very effective as well to help explain the protections that we're doing. Do you have additional thoughts, Anna?
Thank you very much. I think I was just talking to our non-communicable disease department. You know, many of them had actually been recruited to go and work on the COVID side. And then I actually drafted something for them to say, you know, look here, you could actually use the COVID scenario to actually improve your cancer services. So you can actually do both at the same time, and then it will help you such that at the end of COVID, you now have infrastructure, you know, because whilst infrastructure for COVID is being built, you can actually use that same infrastructure for cancer services. Things like decentralization of services, because I've noticed that the HIV community in my country, a lot of them, you know, patients, they are decentralized up to the village level. And if similar, you know, if there was linkage between the two diseases, we could be actually making sure that we have got facilities for our cancer patients up to the grassroots level.
So I'm cognizant of the time because I want to hand it back at the end for a couple minutes for announcements. But on that issue of infectious diseases and the communication, and you've talked about the HIV patients, Edwards, you brought up, you know, the difference in perception between the NCDs and versus infectious diseases. Did you want to expand on that a little bit?
Yeah, thank you for that opportunity. I was just thinking aloud, looking at Malawi's perspective. So from what we see in Malawi, it's not different from Uganda or Kenya. So the things I just highlighted are just among others, the many things and challenges that we face together. So number one, sociocultural issues have got a bearing on how we look at cancers versus infectious diseases. So for instance, COVID-19 is an infectious disease. People look at these acute conditions as much more life-threatening as opposed to non-communicable diseases. Secondly, you may wish to understand the Malawian community looks at cancer as a death sentence. So that in itself has got its own implications on how the community understands, let alone the government. When it wants to prioritize where to channel resources, they would want to prioritize on the infectious disease forum as opposed to the communicable diseases. Because say for instance, as a country, we don't have a radiotherapy machine. And then for someone who would require radiation would need to be referred outside. And the same resources would be used by so many people suffering from malaria. So that in itself has taken a center stage, so much so that there is that disparity between how we perceive, how we approach, how our systems are in regarding cancer care as opposed to. So I agree with Benda and Anit to say, yeah, factor, but I think those are the issues that we are facing as Sub-Saharan Africa in how to fight for this. So with what Anna has also highlighted, I would agree to say this can pose a greater opportunity or learning opportunities from now onwards on how best we can manage cancer. So we have to advocate really and maybe use the infrastructure for the same. Exactly.
Oh, Julie, you are muted. Sorry. Can you please unmute yourself?
I'm sorry. I think that I think Benda said early on how she was amazed at how much money could be freed up right away when COVID hit, and it was sitting there, and should we have been using it for cancer and other things? So I think we need to let COVID settle down, and then maybe we can come back with some learning points from this, and you know, show the numbers, show the deaths, show how many people are impacted, and say, you know, we've got to protect from pandemics and the next pandemic that will undoubtedly come, but also cancer is a huge killer, and we've got, you know, if the money is there, we've also got to put it into that. And so with that, we're running out of time, and it looks like I should turn this over to Christine for an announcement at the end of this session.
Hi everyone, I will turn over to Mishka. She has 2 announcements. Please, Mishka.
Hi, thank you. And thank you all for this fantastic presentation and session today. For our next session, I hope you all saw my email. We are actually going to cancel the June 25th scheduled session, which was supposed to be on telehealth. We're going to combine it into the July 9th session, which is looking at dealing with cancer treatment in countries with limited treatment access and, you know, during the pandemic. And so the telehealth component fits into that. In lieu of the June 25th session, I've also sent you an invitation to the Academic Global Oncology meeting, which is co-hosted by the Center for Global Health at NCI, together with the American Society of Clinical Oncology. So when the link for that meeting is available, I will also send that, but I hope you all received the invitation. If you did not, email me and I'll make sure you get that as well. So thank you all, and I turn it back to Annette for final words.
Yeah, thank you so much, Mishka, for the great announcements. Thank you so much, Dr. Julie, for the great moderation and the discussion. It is really interesting, and I would like members, if they want to continue the discussion, we can do it on the base camp. And for me, what I've seen is like we have to continue advocating and advocating and advocating for cancer care and the attention given mainly to do with the decentralization, so that all the people involved in caring of the cancer patients speak the same language and they have the same interests. And of course, I liked Julie's suggestion of improving communication among the health workers. Some of the things are not going to go away tomorrow, the other day. Sub-Saharan Africa has so many challenges, but explaining to our patients the context. I liked your why way of doing things, the considerations we have to take, why are we doing, and the commitment to them that I'm going to be the one looking, and that is going to, even if it is terminal illness or end of life care, they will have a good quality of life at the end of it if they know that somebody is committed and they have understood the context into which they are falling sick and getting all the challenges. So it looks like we have come to the end of the session. I would like to thank you all for attending, and most especially thanking Benda for the great presentation and Julie for taking us through the discussion. And I look forward to seeing you on 25th June and then to the July session. Thank you so much. Take care and stay safe.
Thank
Bye,
you, Annette.
everybody.
Yeah.
Thank
Thank
you.
you.
Bye.
Bye, all.
Bye, everyone.